Hi and welcome back to another video of Medic Notes. This video is on femoral neck fractures. Femoral neck fractures are common injuries to the proximal femur, associated with increased risk of avascular necrosis and high levels of patient morbidity and mortality. Diagnosis is generally made radiographically with orthogonal radiographs of the hip. Treatment is generally operative with open reduction and internal fixation, versus arthroplasty, depending on the age of the patient, activity demands and pre-injury mobility. Femoral neck fractures are commonly seen in aging population, and more common in women than in men. For its healing potential, femoral neck is intracapsular, bathed in synovial fluid, also lacks periosteal layer. Therefore the callus formation is limited, which affects healing. Its mechanism is usually high energy in young patients and low energy falls in older patients. Associated injuries are femoral shaft fractures, where 6 to 9% are associated with femoral neck fractures. The most common classification is the Garden classification. Type 1 is incomplete fracture, with valgus impacted. Type 4 are complete fractures. Type 2 is non-displaced. Type 3 is partially displaced. Type 4 is completely displaced. Another classification is the Pauwels classification, based on the vertical orientation of fracture line. Type 1 is less than 30 degrees from horizontal. Type 2 is 30 to 50 degrees from horizontal. Type 3 is more than 50 degrees from horizontal. For its clinical presentation, in impacted and stress fractures, patients complained of a slight pain in the groin or pain referred along the medial side of the thigh and knee. Whereas for displaced fractures, there is pain in the entire hip region. On physical exam, in impacted and stress fractures, there is no obvious clinical deformity. Patient might have minor discomfort with active or passive hip range of motion, muscle spasms at extremes of motion, and pain with percussion over greater trochanter. Whereas for displaced fractures, the patient's leg will be seen in external rotation and abduction, with shortening of leg noted. For imaging, hip X-ray AP, lateral, and full-length femur can be done. CT may be helpful in determining displacement and degree of comminution in some patients. MRI may also be helpful to rule out occult fracture, however not helpful in reliably assessing viability of femoral head after fracture. Bone scan may be helpful to rule out occult fracture, but not helpful in reliably assessing viability of femoral head after fracture. And a duplex scanning can be done to rule out DVT if delayed presentation to hospital after hip fracture. Treatment can be non-operative or operative. Non-operative may be considered in some patients who are non-ambulators, have minimal pain, and who are at high risk for surgical intervention. Whereas for operative, there are a few surgical options. Closed reduction with cannulated screw fixation. Indicated in non-displaced transcervical fracture, Garden 1 or 2 in the physiologically elderly, or displaced transcervical fracture in young patient. Second, open reduction internal fixation. Indicated in displaced fractures in young or physiologically young patients, and it is indicated for most patients below 50 years of age. Third, hemiarthroplasty. Indicated in debilitated elderly patients or metabolic bone disease. And lastly, total hip arthroplasty. Can be done in older active patients, patients with existing hip OA, and Garden 3 or 4 in patient below 85 years old. For complications, there might be osteonecrosis due to AVN, non-union, and dislocation. That's all for this video. Thank you.